So atrial fibrillation is what we call an irregular heartbeat. And what happens is the atria, which are the chambers that collect blood in the heart and then squeeze and pump it to the ventricles, what we call priming the ventricles to give it a little boost before the heart squeezes blood around the body and to the lungs. Now, what happens with atrial fibrillation is the atria don't squeeze, they don't prime the ventricles, and they just sit there and quiver, a bit like a jelly. And when you see a fibrillating atrium during surgery, that's kind of what it looks like. It's quivering very quickly. That has a number of disadvantages. It makes your heart beat irregular. It gives you the sensation of palpitations, of an irregular heartbeat, and that can be quite unpleasant for patients. Doesn't feel very nice if you're aware of your heartbeat going all over the place. Secondly, because it doesn't allow the heart to fill properly, because it doesn't give it this oomph to prime the ventricles, the cardiac output, so the amount of blood coming out of the heart, how efficiently your heart is functioning, goes down probably by about 10%, and that can make patients very symptomatic. And symptomatic in terms of you feel tired or you're breathless on exertion. And some people have very mild symptoms, and some people have terrible symptoms. It completely floors them. And the third thing it can do to the heart, or the risk with the heart, is that because the atria quiver like a jelly, the blood flows slowly through them, and the risk is that the blood can then pool in little bits of the atrium that stick out. And there's one particular area on the left side of the heart called the left atrial appendage, and that's got lots of what we call trabeculations on the inside, meaning it's not a smooth surface on the inside, it's all roughened up. And if you have slow flowing blood there, it can form little clots of blood within the trabeculations. And the risk with that is that blood clots come out and cause, well, what we call in the jargon is an embolus. So it's a bit of clot that travels around the body. And the great worry is if it goes up to the brain and causes a blood clot in the brain or a stroke. Well, there are a number of risk factors: high blood pressure, being overweight, and obviously with what I do, valvular heart disease is another issue, particularly disease of the mitral and tricuspid valves that leads to stretching of the atria. In many people, it can be cured. In some patients, it can't be, and the risk factors that lead to it being permanent and not being able to be cured are the duration you've had atrial fibrillation and the size of the atrium. And we will, if you see a doctor about atrial fibrillation, be it an electrophysiologist or a surgeon who specializes in heart rhythm disorders, then they will bear those two factors in mind in coming to an assessment. And there are various things we measure when we do the echo scans to look at the size of the atrium, and then balancing those two risk factors, or not risk factors, but balancing those two criteria, we will then come to a decision about how best to treat you. And there are various options. One is tablet treatment. Number two would be no treatment. If you have had atrial fibrillation for 20 years and the atria are massive, then it just can't be fixed. But there are other options, such as a percutaneous ablation, which that wouldn't be my area to speak about. But in terms of what I do, we offer surgery for atrial fibrillation, which can be performed using minimally invasive techniques, such as a procedure called the Cox-Maze 3 or the Cox-Maze 4 procedure. So very easily, in fact. So if you think you've got an irregular heartbeat, then you just need to visit your GP, and he can do a 12-lead ECG, and even request a Holter monitor. Now, a Holter monitor is a more prolonged recording of the heart rate, where we attach a monitor to you, and we leave it with you for 24, 48 hours, even 7 and 14 days if the irregular heartbeats are very infrequent. So it's very easy to diagnose. So in terms of surgical options for atrial fibrillation, as a rule, we always start with the least invasive option. And so the least invasive option would be a percutaneous ablation done by a cardiologist, an electrophysiologist with a specialist interest in treating atrial fibrillation. But some patients, by virtue of the size of the atrium or the duration of the atrial fibrillation, are not suitable for that, and will come straight for surgery. So I think there are two types of patients that come for surgery: those that have had prior ablations, and those who have not had prior ablations, but where we don't think we can get a good result with a percutaneous ablation. And as a rule, to my mind, surgery has the benefit in treating the more difficult to treat atrial fibrillation. Now, we divide atrial fibrillation into 3 kinds. So paroxysmal, meaning it comes and goes; persistent, meaning it's there continuously, but it's been there continuously for less than a year; and long-standing persistent, meaning it's there continuously but more than a year. And I think surgery has the biggest benefit in the more difficult to treat atrial fibrillation, such as long-standing persistent atrial fibrillation and some persistence. But I think the bulk of that would be the long-standing persistent atrial fibrillation. And the success rate of surgery is very high, and it can be done using minimally invasive techniques. So through a 4-centimeter incision on the right-hand side of the chest, but it is heart surgery, and it is done. We do the lesion set, as we call it. So we freeze around the pulmonary veins of various parts inside the heart under direct vision. So the heart is stopped, the patient is on a heart-lung machine just to support the body whilst we're inside the heart, forming the lines of ablation. And the lines of ablation have all been worked out since the 1980s, since a surgeon called Jim Cox figured it all out on dogs with atrial fibrillation. And they worked out what parts of the heart to electrically isolate to stop the atrial fibrillation. And they did what Jim Cox devised, a procedure called the Cox, after his name, maze procedure, because it was a maze-like series of lines within the left atrium and the right atrium that prevent the atrial fibrillation propagating through the heart and allow the sinoatrial node to fire off. That's where the normal heartbeat comes from, and to travel through the atrial septum to the next bit that needs to be propagated to keep a regular heartbeat. The Cox maze procedure went through several iterations: Cox maze 1, Cox maze 2, Cox maze 3. And they found with the Cox maze 1 and 2, they found there were a couple of issues with 2 of the lines of ablation. So the Cox maze 3 was redesigned to avoid that, and it was originally done in what we call a cut and sew manner, meaning the surgeon would use scissors or a scalpel blade to divide various parts of the atrium and then stitch them back together, and that would create a full thickness scar, which would then prevent the electrical impulses within the heart being propagated. But now the problem with that is it was, first of all, very complex, but all the surgical divisions within the heart created the risk of bleeding. These days we can do it by freezing or burning, so we don't have to cut the heart, so that risk of bleeding is much lower. And we, as I said, we can do it with minimally invasive techniques, so patients can be back to normal probably in about you know, 4 weeks, 6 weeks maximum, and with success rates that are very high. You know, so for patients with long-standing persistent atrial fibrillation, so maybe who've had atrial fibrillation for several years, may have been told that there's no treatment options for them, then the chance of getting them back to sinus rhythms, that's normal heart rhythm with a single procedure, would be 80% plus, and that would be off antiarrhythmic drugs at 1 year. So it's a highly successful procedure. You know, it's been modified over the years, and we don't have, you know, we can use energy sources, so we don't have to cut the hearts, and the risk of bleeding is massively reduced now. We can do it with minimally invasive techniques, a faster recovery, and I think it's going to be a big growth area for the future as patients find out about it.